Welcome to the press briefing. With us today are Dr. Edwin Choi, Controller, Center for Health Protection, Dr. Albert Au, Principal Medical and Health Officer, Center for Health Protection, and Dr. Larry Lee, Chief Manager, Hospital Authority. Dr. Choi will first speak. Good afternoon. I would now report the situation with the fifth wave of the epidemic and the situation at residential home before I defer to the other speakers. From this chart, we could see that since the fifth wave started, we saw more than 1.07 million cases detected through rapid antigen tests and PCR tests. The pandemic peaked in early March. Subsequently, the pandemic eased in the past 3 days. The daily caseload ranged from 12 to 14,000. In terms of outbreaks in residential care homes, we saw serious outbreaks in the fifth wave. As of yesterday, 780 care homes, or more than 90% of the total, were affected, involving some 34,000 residents, making up 45% of the total. The number of affected staff members were 8.7 thousand, or 29% of the total. Outbreaks at residential care homes peaked in early March, and subsequently the number of cases is in decline. At its peak, there were 3,000 to 4,000 new infections every day among residents and staff members. Recently, we have had about 500 cases per day. RATs can help residential care homes identify the infections, and cases could be reported immediately, and infection control and isolation could be facilitated. Vaccination would help reduce the number of cases and deaths at residential care homes. Before March the 18th, for residents at residential care homes who received at least one dose, the take-up rate stands at about 55%. For those who just contracted COVID-19, they would have to wait for a period of time before they can receive the next vaccine. Our objective is to vaccinate all eligible residents in April so that we can reach a 90% take-up rate. I'd like to thank the healthcare professionals, including the outreach teams and various medical institutions, and I'd like to thank the outreach doctors as well as staff working in residential care homes and their families. I urge all eligible residents to get vaccinated if they haven't already done so. Going forward, we must focus on elderly people in the community. For those aged 70 and above, the vaccination rate is about 70%. In other words, about 280,000 elderly people aged 70 and above are yet to be vaccinated. So we urge all elderly people to receive the jab. Hopefully, by the end of April, the vaccination rate for this cluster can reach 90%. I now defer to Dr. Au. Good afternoon. I would now report the information from the CHP from March the 23rd. For those who tested positive through PCR tests, there were 4,520 cases, case number 70090 and 705158. Among the 4,520 PCR positive cases, there were 773 cases detected by the HA. 234 were identified through the public health laboratory. The remaining 3,243 were found through private laboratories. Yesterday, there were 7,990 cases who tested positive via RAT. In other words, yesterday, there were 12,240 new positive cases. So far in the fifth wave of the pandemic, we recorded some 1.07 million positive cases, including 692,521 through PCR tests and some 382,000 through RATs. Among the positive cases yesterday, 4 were imported. The remaining were all local cases. In terms of genome sequencing, the public health laboratory analyzed 1,033 cases. The L452R strain was not found. 1,061 samples tested positive to L452R. In other words, they were Omicron cases. For the remaining 12 cases, the viral load was too low. From the 19th to 21st of March, private laboratories also carried out genome sequencing on some positive samples. 3,266 positive samples were analyzed. Again, the L452R strain was not found. All of them tested negative to L452R, so we believe that these were all Omicron cases. In terms of residential care homes, there was a new residential care home saw a new case. There were no new cases at residential care homes for the disabled. Altogether, in the fifth wave of the epidemic, 781 RCHEs saw cases or outbreaks. In the past 2 weeks, 72 extra residential care homes saw outbreaks or cases, making up 9% of all RCHEs in Hong Kong, involving 1,780 residents and 342 staff members. For RCHDs, so far in the fifth wave, 283 RCHDs saw cases or outbreaks. 44 saw new cases in the last 2 weeks, making up 13% of the total, involving 810 residents and 280 staff members. In terms of deaths involving RCHEs or RCHDs rose to 3,370. In terms of overall death rates, so far in the fifth wave of the epidemic, Hong Kong recorded 6,356 deaths, up 205 compared with yesterday. The latest mortality rate is 0.59%. They were aged 11 months to 102 years old. The median age was 86. Among the 6,356 cases, 7 involving children, 254% or 4% involved adults aged 18 to 59, 1,588 involved elderly people aged 60 to 79, or 20% of the 25% of the total. The remaining 4,499 cases involved elderly people aged 80 and above, making up 71% of all deaths. The public health laboratory conducted whole genome sequencing on the relevant samples. Samples from 297 deaths were analyzed. 24 tested positive to L452R. In other words, these were Delta cases, making up 8% of all samples. The remaining 257 samples tested negative to L452R. In other words, these were Omicron cases, making up 86.5%. The viral load was too low in 16 samples. In terms of vaccination, the CHP analyzed the cases of death. Among all deaths, from the latest figures, for those who were unvaccinated or only received one jab, the death rate was 1.69%. For those who received 2 shots or more, death rate was 0.1%. So there was a difference of 17 times. For elderly people aged 80 and above, for those unvaccinated or those who only received 1 shot, death rate was as high as 11.25%. For those who received 2 shots or more, death rate was 3.22. The difference was 3.55 times. That's all for my report. Can Dr. Lee brief us on the situation at DHA, please?
We have 11,485 patients who are in North Lantau Hospital Infection Control Center, X-ray Infectious Disease Center, and AWCTF for treatment. 38 patients are in critical condition. 23 are unvaccinated. 73 in serious condition. 103 critical patients are in ICUs. As at 00 hour, 170 patients passed away, 93 male, 77 female, ranging in age between 29 and 106. Of those who passed away, 82 came from the homes, 106 are unvaccinated, 41 with 1 shot, 19 2 shots, and 4 3 shots. 162 above the age of 65. There are a number of younger patients who passed away. The highlight a 30-year-old female, unvaccinated. She suffered from underlying conditions with mobility problems. On March 18th, she had an RAT testing positive. She turned up at the A&E of Yanchai Hospital on the 19th of March, nighttime, with fever, shortness of breath, and a little bit of unconscious. And we had antibiotics administered on her. Her condition deteriorated on the 22nd of March. She passed away at about 2 a.m. Second, 58-year-old male, also unvaccinated. He was a chronically ill patient living in a home. On March the 9th, he turned up at Queen Mary Hospital, A&E, for fever and shortness of breath, and she was hospitalized. He had pneumonia. After treatment, the RAT was negative, and he was transferred to Tonghua Hospital on the 16th of March. But on March the 21st, the condition deteriorated rapidly, and the oxygen in blood dropped substantially. And on March 22nd, he passed away. The third patient, 59-year-old male, with 2 shots of vaccines. He's terminal cancer. On February the 7th, he turned up at Queen Mary Hospital for shortness of breath. The X-ray showed pleural effusion in his lungs. And at Queen Mary Hospital, he was under treatment, and he was transferred to the Grantham Hospital for rehabilitation. That was February the 9th. He had oxygen treatment all the time and had to have antibiotics treatment. On March 21st, he tested positive, COVID positive. He was sent to an isolation ward, and on March 22nd, he passed away. 29-year-old male with 2 shots of vaccines. He had thyroid disorders. On the 27th of January, he turned up at the A&E of Tuen Mun Hospital for medical attention. He had fever for 2 weeks with swollen legs and shortness of breath. Our diagnosis at that time was the thyroid storm. And he was given treatment, and his condition fluctuated a little bit with persistent fever. He was administered antibiotics and other drugs. And on March the 3rd, he tested COVID positive. And on the 22nd of March, his condition deteriorated sharply, and he was unconscious, and he didn't respond to any resuscitation. And on March 22nd p.m., he passed away. The cause of death was indeterminate. He was referred to the coroner's court. There are some delayed figures. There were 35 patients who passed away. They were unannounced. 21 male, 14 female, ranging in age between 51 and 102. There are 1,458 patients who have recovered and been discharged, and there are 20 patients who were picked up as COVID positive upon admission screening, and 40 are close contacts. There were 20,184 staff members who have been infected, and 14,859 have resumed their posts. Right, and now I'll throw the floor open for questions. Please identify yourself. Please confine yourselves to 3 questions. Now TV. About the contact tracing work, are you contact tracing the household contacts? Now for the RTD operations, mainly you are covering the residential dwellings. Now you are reintroducing the CTNs without any contact tracing. What's the purpose of that? Under what circumstances would you contact trace all these itineraries of the infected people, and will the positive patients be sent to the quarantine centers? And Omicron mortality, there seems to be a high mortality rate. What are the reasons why Omicron caused more death than Delta? And also, on 19th of April, the in-person classes will resume. What will be the COVID level at that time, according to the CHP? Will this lead to another round of outbreak? Do you think that there will be more people on the street? And what are the risks of class resumption? Right, let me say something about the strategies of case investigation and the mortality situation, and then I defer to Dr. Au. When we receive a case, we would try to control the case, but because of the sheer number of cases, it would be hard for us to trace, contact trace, and all their whereabouts like before. We have the information portal. We would get access to the fundamental information like the workplaces, the address of the workplace, the occupation, the residential address, and so on. We also get to know about the family members. So with these instant data, we would be able to work out whether there are certain places where there is a large outbreak. Now, previously, we had the sewage surveillance, which would give us some ideas about the cases. Now, with ramped up laboratory capacity, if there are more cases in a block of flats, we will be conducting tests. The idea is if someone is testing positive, then they will be able to try and reduce the chances of transmission. In a household, there are isolatees. Now, if we pick up these positive cases, we can distribute the anti-epidemic kits. The positive cases, if they need to seek medical attention, arrangement can be made. Second, at home, we can provide support like information and the rapid antigen test kits. We are resorting to these means to let the public know that once they are infected, they can self-isolate at home, and if they want to isolate at the isolation facilities, this can also be done. As to the fatalities, we look at the numbers in other places. We can see that Delta causes more mortalities by comparison with Omicron, and for the Omicron casualties, normally they are elderly people who are unvaccinated, and because of the sheer number of infected people, the number of fatalities is also higher, and we have to look at each and every mortality case to identify the causes and whether the death was caused by COVID, or some cases have to be referred to the forensic pathologist for further investigation.
復課等等嘅安排咧。
In terms of the future arrangements on the resumption of classes, as you know, social distancing measures will be relaxed gradually, and such relaxation would be based on the present and coming number of cases. As Dr. Au said, the caseload currently remains at a high level, even though it has declined from the peak of early March. We are now at 12 to 14,000 cases per day. When the social distancing measures are relaxed, there will be corresponding measures. Wearing of masks would still be important in preventing cases. We will also identify there's any unreasonable rise in caseload or outbreaks in our community. If we continue to see a declining trend and that vaccination rates could be boosted across different clusters, our social distancing measures could be relaxed in a gradual manner. Dr. will tell us more about case tracing. Currently, we make use of two platforms to collect the particulars of patients, including the RAT declaration system and an information platform on COVID-19. For those who tested positive through RAT or PCR, please provide the particulars as soon as possible, including their address, details of their household contacts, workplace address, etc. There was a question on Omicron and Delta. Among the mortalities, the public health laboratory would conduct genome sequencing on the samples to identify any irregularities, for instance, mutations or virus strain previously unseen. So far, 297 samples were analyzed, including 24 Delta cases, or 8%. 257 were Omicron cases, making up 86.5% of the total. In terms of the mortality rates, we must identify the number of deaths among Delta patients. In the fifth wave of the pandemic, Delta cases only made up a small percentage in Hong Kong. For cases proved to be carrying the L452R strain, there were about 700 cases. If we are to calculate the mortality, we must look at the denominator. In the fifth wave, the majority of cases involved Omicron, so the mortality rate for Omicron was actually lower than that of Delta. Next question, please. The gentleman on the back row. Good afternoon, this is TVB. I have some questions on compulsory testing notices. CTNs would be issued based on the sewage surveillance outcome. On what basis would restriction testing declarations be made? Why don't you focus your resources on RTDs? Would that be more effective? You started acknowledging RAT positive results, and you said RATs were relatively accurate. Would you consider setting up another platform for those who tested positive through CTNs instead of having to undergo PCR tests? You said earlier that the authorities would analyze cases of deaths among patients who died of COVID and died with COVID. Can you share these figures with us? I would address the questions on CTNs and RTDs, and I would defer to Dr. Lee on the cases of death. We currently adopt different anti-epidemic measures. First, RTDs would be issued based on the sewage surveillance results, and during the RTD operations, residents would be asked to stay home. The second strategy is to issue compulsory testing notices. When caseload was low, we would issue CTNs on restaurants, and as the number of cases continue to climb, we must strike a balance between the public acceptability. We saw a large number of cases in certain premises. That's why we use the Leave Home Safe app to issue notifications so that members of the public can receive PCR tests. Our RAT declaration system was the third measure to allow members of the public to declare their positive results. The RAT arrangement started in March the 7th, and we are still analyzing the information. Our RTDs and CTNs would still adopt the gold standard of PCR tests. The RAT declaration system allows members of the public to declare their positive RAT results in a convenient manner. In terms of past cases of mortality, I believe the HA has been closely monitoring or analyzing these cases. We saw some deaths among children, and we would carry out investigation to find out the cause of death. The HA was also looking at other cases, and we have no figures to share so far. Dr. Lee, we must consider different factors such as the vaccination record, the presence of any chronic illnesses, whether resuscitation was administered. So upon completion of our investigation, we would announce the results. I'm from News. I have two questions. Yesterday, the Food and Health Bureau said that CTNs would be reinstated, and those in high-risk areas would have to undergo PCR tests. RAT kits were distributed to members of the public. Why is RAT not accepted under compulsory testing notices? If cases went undetected, would the risk of transmission increase? The pandemic peaked in early March, and it is expected to ease in an efficient manner. For those who did not, some people didn't report their positive results. In that case, would it be difficult to confirm that the pandemic is in decline? Can you repeat your second question, please? The second question. Some experts said the pandemic already peaked earlier in March, and it is expected to ease quickly. So for currently, a lot of people who tested positive did not declare their results. So does it mean that the state of the pandemic could not be indicated by numbers alone? I would answer the question in Cantonese.
Well, when we do the CTN and RTD, we work on the basis of the PCR test, which is the golden standard. If people are already a positive case, like they have already tested positive PCR or RAT, then during the RTD operations, they don't really need to undergo the PCR test because the transmission risk has been reduced. Now, for the COVID positive cases, we do have the record, and they don't really have to undergo the RTD tests. We adopt the golden standard, the PCR test, and as time goes by, we will work out the next strategy. But at the moment, the golden standard is the PCR test. From the statistics, the peak happened in March, and then it was on the way down gradually. As to on the two platforms, whether we can get to grips with the total number of infection, it may not be complete because some didn't quite get tested with Omicron. Some are asymptomatic, and there is no incentive for people to undergo any tests, so they may slip through the statistics. Now we are trying to observe the trend with the statistics. There are some residents who may not go get tested, and their behavior may be the same, but there are some people who are required by the companies to go for testing, or they may have symptoms and they go for testing, and that these trend would be very important to us. Other than the trend and the statistics, we do have other ways to observe the situation, like the sewage samples. That would be more objective because the sewage sample, whether you've undergone any testing, the sewage sample would be very objective. And also, there are certain people who undergo testing every day, like the healthcare workers and the cross-boundary truck drivers, for example. If from their tests, we can observe the transmission situation in Hong Kong. Well, we are observing a downward trend, but in other parts of the world, at the plateau, there would be some fluctuation. It would not be going straight down. It might dip a little bit and go back up. These kind of fluctuation would continue. So statistically, we have to look at the entire trend. I don't think we should let our guard down. Once the number dips, we would be under the illusion that the COVID has been under control. I think we have to keep looking at this. English question, lady over there in the middle, please.
Good afternoon from SCMP News. A few English questions. My first question is related to the CTN resumption. So does this mean that even if the government resumes the CTN and do PCR tests, does it mean that more positive cases will be coming from those who have previously gotten COVID before? Will they be treated as new cases? My second question is travel requirements for children. If an adult has a medical exemption for a vaccine, can the kid travel to Hong Kong with them? And can the kids also leave hotel quarantine on day 7 if they test negative 3 times because they're unvaccinated? Or do parents have to make sure to do a 14-day hotel booking if they are traveling with unvaccinated children? My third question is on vaccine pass. With the vaccine pass requiring 3 doses by May 31st, does it mean that inbound travelers will also need 3 COVID doses to be considered as fully vaccinated? And when will the CHP change the classification of fully vaccinated status from 2 to 3 doses for local residents? And will the status for being fully vaccinated depend on the brand that they receive too? Thank you.
Okay, thanks for the questions. So regarding the compulsory testing notice or the RTD, the restriction, the testing notice declarations that we have been doing for quite a certain period of time. So for those who are recently infected, either by the PCR or nucleic acid test or the rapid antigen test, we consider that it is a recent infection. So for those with recent infections within 3 months, so we don't need them to go to the testing at the compulsory testing notice or under the RTD. So it is to avoid, first of all, the transmission risk when the patient is in active infection. And the second is because we know that the sensitivity of the PCR is quite high, that we may pick up some positive case with residue the nucleic acid in the specimen. So we reduce all this uncertainty and some difficulties for the citizens to do the testing and also the management issue. Okay, so your second and first question relates to the imports or the arrival arrangement. So I think my other colleagues will have a more elaborations on the arrival, the procedures and also the arrival arrangements. But in short, for those accompanying minors without a full vaccination or they still haven't got vaccinations, the arrangement actually is like before. So we are just streamlining the arrangement of the flight suspension or the flight suspension of 9 countries, but the arrangement is similar before. So, but the details will be explained to you later by our colleagues. Okay. So about the arrangement of the accompanying minors. So for the vaccine pass of the arrival passengers, so indeed we know that there are different vaccines schedules in different countries. Like for some vaccine, there are only requirement of 1 dose instead of 2 doses, and some require 3 doses in certain countries. So we'll respect the arrangement in the overseas countries to regard this is a complete and fully vaccination. So in summary, the arrangement is similar to those in before. Okay, thank you.
下一題，隔離嗰位女士。
Next, the lady, Ming Pao Daily. Taiwan Hengman State Hengfed House. There is an infected man who passed out and then passed away. Now, when was he tested positive? Did he take any oral pills? Now, this question is for HA. There are younger patients who died today. Did they die with or die of COVID? Now you are issuing the CTNs to buildings. What are the objective criteria? Do you have any particular threshold before you impose this RTD operation on them? Now for the CTN, I defer to Dr. Au for further supplement. I think for the first case you mentioned, I don't think I have the information. It's hard for us to address the issue from the brief information that you gave. Dr. Lee announced some diseased cases. Perhaps Dr. Lee can supplement. Right. The case in Taiwan, we learned of this news. We are trying to understand the situation. In absence of any particular information, I cannot say anything about the cause of death. Now, for these cases, if they are related to COVID, we do have the mechanism, we do have the procedures to refer them to the coroner's court, and we will bring the media up to date. On the younger deceased patients, I mentioned 4 today. That the 30-year-old female, 58 and 59 males, they are related to COVID. But the last case, the 29-year-old male, we think that it is doubtful whether it is related to COVID. And according to some experts, this may not be directly related to COVID. I think it's best referred to the coroner's court to work out the cause. A little bit supplement before I hand you over to Dr. Au. Now for the CTNs and RTD, and also the RAT, I emphasize that for RTD and CTN, we are working on the basis of the PCR tests. However, during the CTN, if we have an infected case who has been confirmed using PCR or RTD they don't have to undergo any further testing because we don't really want them to transmit the virus. And it is likely that there are still some remnants of COVID that might affect the result.
或者我哋做
When we issue CTNs or conduct RTDs for residents who just tested negative through RAT, they must still receive PCR tests under the CTNs or RTDs. In other words, an RAT positive result doesn't exempt someone from receiving the test. But for those who have declared their positive results through the RAT declaration system, they would be exempt from the PCR test. For those who tested negative through RAT, they must still fulfill the testing requirements under CTNs or RTDs. Thank you. The CTNs are based on a risk-based approach. We would select venues of relatively high risk, mainly these are residential buildings. Through two separate systems, we would receive reports from individuals who tested positive through RAT or PCR, and they would furnish basic particulars such as their place of residence, occupation, workplace address, etc. We would select premises or facilities with a relatively high number of cases for CTNs. For premises or buildings already included under CTNs, CTNs would not be issued again. We identified premises including residential buildings. Through both systems, we would collate information that were reported within the last 7 days in order to identify buildings or housing estates with more cases. We would select residential buildings or estates that were yet to be put under CTNs, since there could be transmissions or invisible cases at these premises. This would be constantly updated on a daily basis. Yesterday, we identified about 10 buildings. Each of them saw more than 50 cases over the past 7 days. Final question, please. I'm from AM 730. First, the 3-month window for those who recovered, they would be exempted from testing. Would the same standards be applied for quarantine? That is, for those who recovered in the last 3 months, would they be exempt from quarantine? Would likewise would patrons in restaurants enjoy exemption? For those in residential care homes, they could receive the Sinovac jab as a second shot. Could they choose community? Inbound visitors will still need to undergo quarantine in a hotel, but many locals are actually completing their quarantine at home. For inbound visitors, is it feasible to allow them to quarantine at home rather than in hotels? That could alleviate the shortage of hotel rooms. In terms of the policy on inbound arrivals, we have always adopted the strategy of preventing local cases as well as importation of cases. For inbound travelers, we want to ensure that they do not spread the virus in the community, and we want to find out the virus strain involved in positive cases. And that is why we must exercise control. Those who return to Hong Kong must first produce a negative test result, and upon arrival at the Hong Kong airport, they must complete another PCR test. We would conduct a rapid PCR test to reduce the waiting time for passengers. If the test result is again negative, they must take designated point-to-point transport to and they would be transferred to a designated hotel, and an RAT must be conducted on specific days to ensure that the traveler is free from COVID. This would minimize the risk of outbreaks in Hong Kong. After we start implementing the arrangement, we will review the measure on a regular basis based on the situation. You talked about people who contracted COVID and have since recovered over the past 3 months. With regards to CTNs or RTDs, those who recovered recently might have contracted disease only recently. That's why we would exempt them from testing so that there's no chance for them to spread the virus. Through PCR tests, we might identify certain re-positive cases, and that is why we would grant exemption to minimize the risk of transmission. For individuals who tested positive in the past, they would still need to comply with our requirements, and we would continue to monitor the situation on a scientific basis. As for the choice of vaccine, we would respect the preference of the public. If they prefer a certain vaccine, we would try to provide that vaccine as much as we can. So we would respect the preference of the public. Some people might feel that certain vaccines have strong side effects and they would like to make their own choice. For the community vaccine, the storage and transportation requirements are more stringent. So in terms of transportation, storage, dilution, etc., we are exploring if certain arrangements could be made. If members of the public prefer another vaccine, we would render support as much as we can. For instance, by allowing residents of care homes to get vaccinated elsewhere. We have a number of vaccination venues right now. So we would facilitate vaccination by working with our partners. This is the end of the press conference. Thank you.